Good morning. The topic allotted to me is acute stroke treatment. And I must thank the organizers for having given me this opportunity. It's an honor and privilege. A special thanks to Dr. P.P. Mohan. You should all, before the start of the talk, I'd like to remind you that stroke is very heterogeneous. And you have all these different kinds of pathophysiological mechanisms. You have penetrating artery disease, that's small vessel disease. You have intracranial, that's medium sized. Then you have large vessels like carotids, which can be affected with plaque and arteriogenic emboli. Then you can have flow reducing carotid stenosis, and you can have aortic arch plaques, atrial fibrillation, the cardiogenic emboli, left ventricular thrombi. So, and from valvular heart disease. So the pathophysiology is heterogeneous, and the cause of stroke is very important before we consider the treatment. Now, the stroke evolution has been in the recent years mainly with thrombolysis. So the main advances have been with intravenous thrombolysis as well as mechanical thrombectomy. And this shows the stroke evolution of treatment, and the trials which are put above that is on the top of the slide is actually intravenous thrombolysis. And the initial ones were all intravenous thrombolysis. And later on, you have a few very recent ones, which again is trying to extend the time window of thrombolysis. And down below, you have mainly the mechanical thrombectomy or the endovascular trials. There is a cluster of them. And the ones which are marked in blue are the antiplatelet drugs, the trials of antiplatelet drugs, Chance, Point, as well as Thales. I'll just make a brief mention of the antiplatelet drugs, but mainly spend on the intravenous thrombolysis as well as endovascular treatment. Intravenous thrombolysis has been there for the last 26 years. It started off in 1996 when the NINDS trial was successful and the FDA approved intravenous alteplase as a treatment for acute stroke. After that, there has been some extension of the stroke, the time window by various trials which are following that. And then you had this extension from 3 to 4.5 hours. So that now IV-TPA is considered to be the standard therapy to give it the first 4.5 hours of stroke. And this is the pivotal trial which by which the IV alteplase was actually approved by the FDA, and you can see the great improvement in the NIH stroke scale, Barthel index, modified Rankin scale, as well as the Glasgow outcome scale. So it was found to be beneficial in all outcome points. So this is a functional analysis, a pooled analysis of 9 trials, and you find that there is a waning of benefit after a certain point of time, and this point of time is now considered to be about between 4.5 hours and 5 hours. So that 4.5 hours is now taken as the time after which the administration of the IV-TPA is not beneficial, no longer beneficial. And there is very good evidence indicating that this is a trial, again, a pooled analysis of 9 trials. I think it's shown that beyond the time of 4.5 hours, you find that alteplase is actually worse, and before that, alteplase is better. And it's given as an infusion. Alteplase is usually given as an infusion over 60 minutes. The 10% of the dose is given as a bolus over 1 minute. It's very important to measure the BP and see that the BP is in the range, that is 180 by 105. And then you have to take the necessary precautions. And the treatment of hypertension before thrombolysis is also very important. And the drugs which are used are usually labetalol is the drug which is commonly used. The other drugs which are approved are nicardipine and clevidipine. The usual drugs and hydralazine and enalaprate are also used. The usual drugs, NTG as well as sodium nitroprusside, are frowned upon because it might increase the ICP and because of the steal phenomenon. So if you consider the benefits versus harm, in the initial hours, IV-TPA is found to have enormous benefit. The NNT is 8, and you can see the benefit versus harm. Harm is this one, and this is the benefit. In the first 90 minutes, the benefits over harm is enormous. and it stays on for the next 90 minutes. That's the first 3 hours, you get a good benefit, and the number needed to treat is 8. While after that, till 4.5 hours, you still have an NNT of 14, and you find that the benefit actually outweighs the harm. But beyond that, you find that the harm outweighs the benefit, so that you don't give TPA after 4.5 hours. So the AHA-ASA guideline, the latest one is in 2018, and there has been some updates. And again, it shows that there is a new indication also for IVTPA, in the sense that IVTPA is now considered in patients with minor stroke in certain circumstances. Otherwise, the PRISM trial had actually actually shown that mild stroke, in very mild stroke, IVTPA is not as beneficial as in the other cases. But in certain cases where even a minor stroke is considered as disabling effect, like in a complete heminopia, severe aphasia, which is again just 2 on the NIH stroke scale, visual or sensory extinction, any weakness limiting sustained effort against gravity, and especially if the dominant hand in a person, for example, a manual laborer or a skilled mechanic or a skilled carpenter, it's very important to consider that when you think of giving IVTPA or not giving IVTPA. So even very minor deficits in which the NIH score is less than 5, you can still give IVTPA, provided these minor deficits are supposed to be non-disabling. And you find that in many cases, if you look at the frequency of patients coming with stroke, you find the frequency is very high, below 6. So the TIAs and below 6, the minor strokes are much higher than the other ones. So that is why most of these people are actually denied IVTPA. So in these cases, you can, this fits this criteria, you can actually give IVTPA. And it's also important to note that urgent anticoagulation, the goal of preventing early recurrent stroke, halting neurological worsening, or improving outcomes after AIS is not recommended for the treatment of patients with AIS. That is again from the ASA guideline. Now there's another question is what agent to use for IV thrombolysis. Another agent which has been tried is tenecteplase. Tenecteplase is not approved in certain countries. In India, it is approved. So we have started using tenecteplase in place of alteplase because it's easier to administer. It's more fibril specific, and it can be given with a IV push. So you don't take that much time to actually administer the dose of tenecteplase. And if you want to drip and ship, that is, if you want to give, a patient comes to you with a large vessel occlusion and you feel that's a patient for mechanical thrombectomy or IV endovascular therapy, then you can always give tenecteplase and then ship the patient to a center where endovascular therapy can be done. So that's the advantage of tenecteplase. Well, alteplase takes about 1 hour to administer. So you'll have to, the drip has to be on flow while the patient is being transmitted. Now, these are the trials. Again, most of these are phase 2 trials with small number of patients. All of them have shown a result which is favoring tenecteplase, at least a little bit. Anyway, it is not inferior to alteplase. So the other, there are various other new trials, that's phase 3 trials, the Extent IA as well as NORTEST have used tenecteplase in much larger patients. And in these patients also, they have found that, especially in Extent IA, where angiogram was done after administration of tenecteplase, they found that there is higher recatalyzation rate with tenecteplase compared to alteplase. So maybe tenecteplase is the drug of the future. So in future, maybe we'll be using more of tenecteplase rather than alteplase. The next group is the endovascular thrombectomy or the endovascular therapy. Thrombectomy, this is, again, this was actually approved by the FDA after a cluster of trials, about 5 trials, which came out in 2015. So that is a time which was landmarked in the treatment of stroke. And this is the Hermes collaboration, where they actually did a meta-analysis of all these 5 pivotal trials and found that in patients with acute ischemic stroke caused by occlusive proximal anterior circulation, there is benefit endovascular thrombectomy is of benefit. That is what they found out. And these are the results which shows that the benefit is there. And they show that the harm is also very little compared to the control population. That harm is, of course, the symptomatic intracranial hemorrhage, which is what people are scared of when you treat acute stroke. Now, again, HERMES is a pooled data analysis of 5 endovascular trials, 634 intervention cases versus 653 controls, median time to treatment 3 hours and 16 minutes, 71% recanalization achieved, and NNT to reduce 1 point in modified Rankin scale was 2.6, which is very high. And very many authors actually believe that it's not 2.6, it's about 3, 4, or 5. Even then, it's very good. And you can see the modified Rankin scale, which shows pretty good improvement in the intervention population. And this is another forest plot, which again shows that across characteristics, you find that it's all favoring intervention. Another problem was whether thrombectomy should be done after alteplase or without alteplase. So this is a trial which looked at that. This is a Chinese study, and it again showed that endovascular thrombectomy alone was not inferior to intravenous alteplase plus endovascular thrombectomy. Some endovascular interventionalists actually prefer alteplase, that alteplase need not be given. I mean, that's how they prefer it. But some people won't mind if alteplase is given. And many neurologists want to give alteplase because in case the endovascular thrombectomy doesn't work or you could not achieve revascularization or opening of the arteries don't occur, at least the patient has the benefit of the intravenous alteplase. And for detecting who is actually in the time window, there has been a few advances, and there are 2 major techniques by which you can see whether the patient is actually in time window. If you don't know the last known well, and the most common situation where you don't know the last known well is when the patient goes to sleep perfectly fine, and on waking up, he or she has a stroke. And so you don't know when the stroke occurred. So the last known well is taken as about, maybe the patient has slept 6 or 7 hours. It's taken 7 hours before, and usually they automatically fall out of the time window. But whereas in actuality or reality, the patient would have had stroke just before waking up. So one way to know this is by detecting the flare versus diffusion mismatch. So the panel on this side, on the left side, is the diffusion, and this is the flare. So if you find a lesion in the diffusion, but the same area there is no lesion at all, then it's called a flare diffusion mismatch, and this is one. And usually the flare lesion takes about 4.5 hours to appear. So as you can see in the subsequent images, you can find that in this one, there is a faint image here which shows that flare lesion is about to appear. And in this one, the flare lesion is much more marked. So this is later than this one. So when the flare is almost equal to diffusion, it means that it's beyond 4.5 hours. And so there's no benefit in treating with IV TPA. So IV thrombolysis can be given in these patients where you have this flare versus diffusion mismatch. And so MR Witness as well as Wake Up are 2 trials which actually looked at this, and they found that if you find this mismatch and you find that it's within 4.5 hours of detecting the stroke, then these patients did well with IV thrombolysis. So these are the trials which were done with, again, this is a Wake Up, this is again Wake Up, and this is MR Witness. So again, they showed this diffusion versus flare mismatch. This is again taken from this trial. And you can see that most of these patients did well when you had a good mismatch between diffusion as well as flare. Another technique of knowing who's in the time window is by looking at the CT perfusion or MR perfusion. So if you have diffusion perfusion mismatch, then you realize that these patients will do well with IV thrombolysis or thrombectomy. Now, these were interventional trials. This is Dawn, which looked at thrombectomy 6 to 24 hours after stroke with a mismatch between deficit and infarct. And they found that these patients actually did well even when treated between 6 to 24 hours. So previously, we know that the thrombectomy, the time is usually 6 hours. And this this Dawn trial was done to extend the time window. So 6 to 24 hours was what they done. So this actually changed the guideline because the stroke guidelines actually changed after this trial, so that patients within 24 hours, you can actually do this sophisticated imaging and see if these patients are in the window for thrombectomy. So Dawn criteria had a very small core and they showed a very good benefit. While this is another trial which again used the similar criteria, again perfusion diffusion mismatch, and then they had a larger ischemic core. They still showed benefit, even though the benefit was not as much as that in Dawn study. This extend trial was again using a perfusion diffusion mismatch. They extended the time window for intravenous thrombolysis from 4.5 to 9 hours, and they found benefit. Though this did not come into the guideline, this is again a trial which shows that we might be able to extend the time window in future. So this is again the aggregation of all these trials, and you find similar to the IV thrombolysis, where the time of benefit is 4.5 hours. In this one, the time of benefit is about 7 hours. So the blood pressure in acute stroke, there were various trials which looked at it, and probably it's safe to keep the blood pressure between 140 to 180 systolic. And it's very important to keep the blood pressure within certain limits, and it's important to remember that the blood pressure should be different in different stages. Like when you take the patient to the cath lab, it should be between 140 and 180, and after perfusion, it should be kept at 140 to 160. And if it's only partially recanalized, it's 180 to 105. So it's different for different stages. This is an important trial, again, the TAILS trial, which again showed that ticagrelor is useful in ischemic stroke or TIA. And but with the caveat that severe bleeding was more frequent with ticagrelor. So in patients who don't respond to or are resistant to clopidogrel, it might be ticagrelor must be useful. And I'd like to stress that stroke units are very useful in reducing mortality. The effect size is actually comparable to TPA, and it's always important to have standardized stroke orders and treatment pathways, adherence to best practices, telemetry, BP vital sign check, neuro check, bedside swallowing, glucose checks, DVT prophylaxis, and temperature regulation. All these make stroke units very useful. Surgery for stroke is done in a few situations. One important one is in a malignant MCA infarction, where you can do a hemicraniectomy, which has been found by 2 or 3 trials to be very useful. Emergency carotid endarterectomy is done when in severe carotid stenosis with a partial stroke. And then this is another case where a posterior fossa, there is cerebellar infarction, space-occupying cerebellar infarction, can do a suboccipital craniectomy plus or EVD plus or minus a suboccipital craniectomy. So in short, in the first 4.5 hours, you have to say IV TPA should be given to every eligible patient. Plus, you should also consider mechanical thrombectomy. 4.5 to 24 hours, you should consider mechanical thrombectomy with the aid of a lot of sophisticated imaging. And these are several scales which are used for pre-stroke management. It's very important to know that. So the time is saved in the emergency department. So for acute evaluation, you have to know the time last known well, history of present illness, exam, NIH stroke scale, inclusion exclusion criteria, and documentation. And this is a triage. So you have to, I think I've covered most of this in the talk. You have to see whether it's a large vessel occlusion, and these patients have to go for endovascular therapy or endovascular thrombectomy. And in patients who don't fit in the criteria, you have access to MRI. You can actually look for a diffusion flare mismatch or a perfusion mismatch and consider mechanical thrombectomy even beyond the time window. To conclude, you have to think of combined thrombolysis with endovascular therapy. Procedural excellence is the best chance for a good outcome. Time is brain. A protocol-based approach saves time and gives best outcome. Stroke unit care matters, and stroke is like cricket. All members of the team contribute, so every member is important to have a very good outcome. Thank you.